diaper off, and it was just hives and welts everywhere. It did get up to, you know, his face area, which then started the panic inside of me, and that's when we rushed to the emergency room.
I remember how scared I was and how serious it felt, and luckily for us, the doctors were able to help, and that's when, to me, it became a serious thing that I needed to really pay attention to.
That's Brittany and Patrick Mahomes describing the day an allergic reaction to peanuts sent their son Bronze to a hospital. Good morning. I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System and Executive Vice Chancellor at the University of Kansas Medical Center. It's great to be back here with you for a new episode of Open Mics with Dr. Stites and our monthly edition of my favorite, Show Me the Science. I love that. That's awesome. Okay, food should nourish us, not put our lives at risk, of course. But for millions of people, a bite of the wrong food can trigger an allergic reaction. Research shows food allergies among children are more prevalent than ever. Today, we're exploring the scope of the problem and learning the challenges faced by the food allergy families, including the Mahomes family. Their foundation, 15 of the Mahomies, has launched a new partnership called 15 and Fair, working with the group Food Allergy Research and Education. Joining me at the desk today is Dr. Marissa Love, an allergist and immunologist here at the health system and also a board-certified pediatrician. And we're thrilled to welcome Sung Poblat, PhD, RN, and the CEO of Food Allergy Research and Education, or FAIR. Great to have you both. Okay, now just to be clear, son, how badly did I mispronounce your last name? I'm really good at that. Tell me, how did I do?
Pretty close. I'll take it.
All right, good enough, because that's what's going to be today. All right, the new partnership, 15 and Fair, recently hosted a back-to-school event for food allergy families. We talked with children and their parents about how they manage their food allergies. Many feel just like the Mahomes.
To peanuts.
I'm allergic to gluten and I have an intolerance to dairy.
What we're allergic to, for the most part, is shrimp and fish, also peanuts, apples, and bananas.
I'm allergic to sesame,
peanuts and almonds.
How do you manage a dairy allergy at school?
I go to their nurse and he gives me my EpiPen. I self-carry and we keep one in the nurse's station, and I normally walk around with a friend at school, not by myself in case I were to react in the hallway. I have to bring my own lunch to school because in case the school lunch has peanuts in it. I get hives and my tongue swells and then my throat swells. If I smell it, it kind of makes my throat close up. It was when I was in preschool and it was like an Easter event. One of the pieces of candy that I got was a peanut butter Reese's. We went to the ER. Sometimes I don't eat a lot of my lunch.
Because you're nervous?
Yeah. If we were to tell a chef that I can't have it, like, don't come back with an answer, like, I'm pretty sure it's not in it, I would like a yes already.
Cross-contamination even counts.
I forget about my allergies, and so I wish that they would be understanding, like that I had a food allergy.
Wow. Tough to watch those little kids. Those little kids have to go through that. Dr. Love, you gave a presentation at this event. What was your message to the families?
Yeah, so it was a really exciting event, and food allergies can be really overwhelming, and so being able to share the stories and give empowerment to the families and the children was most important. And I think that is something that the Mahomes family does really well and shows others that by bringing awareness, it can bring hope and help families feel less alone.
Yeah, and trust the science, right? I love that. Okay, now I'm going to try this again. Dr. Poblete, how was that?
That was perfect.
I see, I rehearsed this last night in front of the mirror, and then the day of right out of the game, but that's all right, You throw an interception the first time, but you still win the game. Okay, Dr. Poblete, how cool to have the Mahomes family involved. When it comes to awareness, what are some of the biggest blind spots people have?
Within the food allergy community, I think we all know that food allergy is a disease, but outside the community, many people don't understand that food allergy is a disease of the immune system, not a diet. Unfortunately, it's often viewed as a preference or a choice, and that can lead to a range of issues from inadequate funding all the way to children being bullied at school, sometimes even by adults. And food allergy moms can be viewed as Karens, and for children, they could even be seen as difficult or being fussy eaters. And at FAIR, we're working hard to build public awareness of food allergy as a potentially life-threatening disease. And we believe that shift in understanding is key to improving research funding, driving innovation, so that there are more options for the food allergy community, and ultimately enabling scientists and researchers to find new treatment options and even a cure.
Well, let's go on that one. Food allergies are getting more and more common. The survey data collected by the CDC National Center for Health Statistics shows that food allergy prevalence among children increased 50% between 1997 and 2011, and another 50% between 2007 and 2021. So the prevalence has roughly doubled since the late 90s. Now, Dr. Luff, why do you think food allergies are more common in children today than in past generations? Is it awareness, or is this something that we're really seeing?
Yeah, that's a great question. We get asked this every day. Grandparents come in and they say, well, we never saw food allergies when I was this young or back in the day, and now it's everywhere. Kids' diets are different today. There's a variation in what they're eating early on in life, maybe less diverse. They're not being exposed to germs early on in life because they have a more sterile environment. And so it changes the what we call the microbiome of the gut. And so there's this idea that with us being more and more clean in our home environments, that perhaps it's changed us a little bit.
Oh, interesting. So it's not just a question of, well, we recognize it more often, although I bet that plays a role. It's also, there's a physiologic thing going on out there, a science thing going on out there.
Absolutely.
Dr. Poblete, what kind of research would help prove what's behind the increase? What do we need to do?
Well, I think to understand what kind of research would help, we have to understand the rise in food allergy. We need to consider the groundbreaking Learning Early About Peanut Allergy, or LEAP study, that has shown that early and frequent ingestion of common allergens can be key in preventing food allergies. This strategy, known as Eat Early, Eat Often, led the American Academy of Pediatrics to reverse their guidelines back in 2019, advocating for early introduction of allergenic foods in infants. And at FAIR, we're aware that new parents and even some doctors may not be familiar with this research and may be following older recommendations. And it's crucial to spread awareness and ensure that everyone is informed about the latest findings to effectively prevent the development of peanut and other food allergies.
Well, the FDA identifies 9 common food allergens here on the screen: milk, eggs, fish, shellfish, tree nuts, peanuts, wheat, soybeans, and sesame. Now, sesame wasn't on that list until 2021. But if you cross the pond, the UK and EU count 14 major allergens, including things like celery, mustard, and sulfur dioxide. So why does our immune system mistake certain foods as dangerous in the first place? Dr. Love.
Yeah, great question. So it's very similar to a false alarm. The body sees what should be non-harmful, a food protein, as harmful, and so it overreacts. And it almost treats it as if it's a foreign body or like a virus. And so the immune system then decides to develop allergy antibodies against it. But that's usually the first step. The second step is that over time, if the patient or the person does not eat the food as much, or all of a sudden is sensitized, they can lose tolerance to that food. So if they don't eat it as frequently, they don't eat it early on in life, they lose what we call oral tolerance. And that is what becomes a food allergy. They develop symptoms.
Interesting. So what is the scientific link between allergies and other conditions like asthma or eczema? Dr. Polity.
The scientific link is called the atopic march, which refers to the natural history of allergic diseases as they develop over the course of infancy and childhood. Classically, atopic march begins with eczema and progresses to IgE-mediated food allergy, asthma, and allergic rhinitis. Each of these are conditions that carry a complex pathophysiology involving multiple facets of the immune system. And you know, I lived in Hollywood for about 12 years before my job at food allergy research and education. And in Hollywood, you want that quadruple threat. You want to be a great actor, you want to know how to sing, dance, and you want to have a secret hidden talent. For me, my quadruple threat was the atopic march, and that's not what you want to have in Hollywood.
Well, glad you could find your way to FARA. That sounds like a little better place for you.
Yes.
So parents are encouraged to slowly introduce their kids to allergens as a way to hopefully desensitize the immune system. Now, how do you do that safely, guys?
Yeah, so and I always tell parents, you know, it's easy to overthink this. And back in the day when we didn't have as much food allergies, you just fed the baby, you know, just feed the baby early and often.
I gave my daughter those little popsicle pop-ups back in the early 90s because I was eating one and I kind of set it here to do something, and pretty soon she was eating it and she was on my shoulder. And I was like, wow. My wife didn't know that at the time because we weren't going to give our kids that kind of stuff. And then one day she put one in a bowl. She goes, look how I eat all that. I'm like, yeah, maybe she's been eating that for a while. So we introduced our kids to all sorts of stuff.
Absolutely. Diverse foods, often increasing the amount of foods that they're being exposed to on a regular basis. That all helps the immune system get trained.
Yeah. So is there any data on how effective this new, or this, maybe it's not new, oral immunotherapy approach is? I mean, we don't do this, we don't give kids the stuff in a pill, right?
No. And actually the only food allergen that is FDA approved for oral immunotherapy is peanut. So that is a peanut oral desensitization where you take very small amounts of the peanut protein over time, and they get to a certain dose. It helps make sure that the body doesn't overreact to small amounts of protein if it was actually accidentally ingested, but it does not cure them of the peanut allergy.
So is this anything like where people say, well, you should have dogs and cats early in life so you're not allergic to dogs and cats, or you're exposed to more stuff, you should crawl around the floor, go out and play in the mud? Is that?
That is very similar to what you're talking about for the hygiene hypothesis.
Yeah.
So, you know, the genetics piece, everyone's genetics sets the baseline risk, and then their environment, whether it be sterile or, you know, messy, dirty, out in the farm, decides on the expression. So I tell families that, you know, you can have this run in families, but the expression of it may be different from one sibling to another. So one might have a food allergy, the other may not.
So are researchers exploring vaccines or other immune modulating treatments for food allergies?
Yeah, that is a great question. That is very much on the frontier of food allergy research right now. And there's a lot of exciting things coming along the way for future treatments of food allergies, such as a skin patch or a tablet that goes under your tongue, or some folks are even trying to see if drops under the tongue are an appropriate thing to use.
Yeah. That sounds pretty awesome. So those are some really good other kinds of approaches that are being studied, that these could help change how we manage food allergies. So anything else besides the one you've mentioned, Dr. Love?
I'm trying to think. Those are the big ones, I would say. And the one that we actually have clinical trials running for right now in the region is the skin patch one. And then there's some oral immunotherapy desensitization trials in the region. And we do have the adult vaccine trial going on as well for peanut allergy.
Pretty remarkable. So what's the biggest challenge that still stands between current science and at least better therapy or even a cure for food allergies?
That is a wonderful question. It's a loaded question.
It is a loaded question, especially because there's a lot of stuff happening in the science world right now.
Absolutely.
Questions about vaccine hesitancy as well as funding for science in the United States.
I think that's a major issue, and Dr. Pobletti kind of alluded to it, is that if food allergy is not even recognized as a scientific chronic condition in the first place, then why would we spend money on it to do research?
You bet.
Why would we spend money on it to do treatment? And I can, defer to Dr. Pobletti on the advocacy piece that they do on the Hill, but that is the first step.
You bet. Dr. Pobletti, let's talk a little bit about that. You talk to us from your standpoint. What are some of the biggest challenges, and how can we continue our advocacy?
The biggest challenge that we see, even though more than 33 million Americans have life-threatening food allergies here in the United States, we receive less than $80 million of research funding today. Compared to other disease states that receive more than $1 billion, for instance, for asthma research, it's sorely lacking for food allergies. So we have to bring more awareness, obviously, for food allergies, that it is not a diet, that this is a very serious disease that could kill individuals, and also advocate for new treatment options. One of the other things that we want to do with food allergies is to bring scientific advances in other fields. So just back in May of this year, we brought together multidisciplinary scientists at MIT, and we took a convergent approach, meaning we brought physical scientists along with biological scientists to make certain that we brought machine learning, AI, and food allergy experts. We brought GI experts. We brought immunologists from different fields to advance and amplify the learnings from multiple disciplines to the food allergy space. And from the 2 days of learning from each other, what we found was there were so many areas that apply to food allergies, and we will be launching a $10 million RFA in the next couple of months so that the food allergy community can work with multiple disciplines across institutions to quickly seek treatment opportunities for a food allergy community.
You know, it's amazing to me that this seems to be still out in the public a little bit of, well, they're not really sick. There's something wrong in their head. What's going on with that? And as someone who's experienced had food allergies later in life arise, or food sensitivities later, which I wasn't aware of, although I probably had them for years. I sympathize. This is hard. And if you can address it early and actually understand it better, I think you can make a big difference in young people's lives. And you wonder how many other health conditions are linked to this question.
Absolutely. I think, you know, we've talked a lot about food allergies, but when we're dealing with adults that have food allergies, you're also dealing with adults that have other conditions: diabetes, heart disease, hypertension, kidney disease. And so you wonder, is it because you had to modify your diet early on in life that now you're at risk for all these complications? Right.
Or you didn't modify your diet and you just ignored it later. That goes back to haunt you. Oh, reflux when you're 17, you're fine. Oh, it's gluten. Who knew that? Oh, now, 50 years later, figured it out. So, yeah, you know, there are all sorts of things that happen to us. That old thing, you are what you eat. All right, we're here to answer your questions. Send them in using the info on your screen. That includes the chat on YouTube or Facebook, or emailing the Medical News Network. Let's check in with Doc Hawkeye.
Yeah.
We fly together again, brother. How are you?
We are back. I'm good. You know,
all right, we've been seeing a little bit of COVID again these past few weeks. It's popping back up. There's a wavelet, and we don't have enough data out there anymore with the lack of CDC information to really fully understand the total grasp of it.
Yeah.
But we know there's some information out there, both in wastewater testing and just some reports. Talk to us about where we are.
Yeah, I mean, I think that's exactly right. Here we have some updated CDC information. Again, we know the caveats are, number one, people probably aren't getting tested if they're not sick enough to go to the hospital or the emergency department. Even if they are, they probably aren't testing at home if they know somebody who's had it. We also know that the lack of reporting, or institutions or states reporting, is a problem as well. What we just saw in that graph there, if we can go back to that, we are going to see just the general line. We want to show you the general line. August 9th is the last date that was identified for hospitalizations, and August 23rd for emergency department visits. As you can see there were a couple peaks there on the left side of those graphs, those lines, as we got to a nadir, a low point in the overall hospitalizations and emergency department visits. But then what you see since that time, really since probably early August, we see this increasing rate or increasing number of hospitalizations and emergency department visits. I think we've also all anecdotally maybe know somebody who's been ill, either for sure with COVID or possibly with COVID. And of course, we know that we've heard the story last week about a local school that was shut down until earlier this week because of COVID illnesses as well. So we know that we are seeing increased amounts of circulation of the virus in our community and in communities throughout the country.
You know, Hawkeye, it's concerning to me that the lack of public health and the divestment, if you will, the withdrawal funding for public health is going to make it harder for us to track not only this particular COVID wave, but anything else that's coming at us. Just to say out loud, the influenza season down in Australia this year was extremely bad. And you wonder, what does that mean for the United States as we head into our winter months between both COVID and influenza?
Yeah, I think that's good to know. You know, the U.S. tracks the southern hemisphere for influenza in particular because their winter is the off time when we are in summer. So we anticipate similar forecast for our illness, particularly with influenza, with the southern hemisphere, South America, Australia, etc. And just as you said, yes. Now that leads to the bigger concern, which you touched on your first point, is public health and medicine overall. We know that there is less resources going to public health in general. We know that is a concern. In addition, we know that overall there is less information being talked about or being reported or being even obtained to help us track and follow these trends. It is vitally important. We know that the health of the community is a vital indicator of the community in itself. We know that illness can affect not just that person, say if your child is sick, but that affects then maybe household income, and people or parents or caregivers now can't go to work because they're home with their children caring for their children. That then leads to lost wages. We know that there is significantly high costs that everybody is dealing with. So it is not just one thing in a vacuum, but it leads to a whole great picture of just worse outcomes or maybe worse situations for people in general in communities.
Yeah, this will be a challenge for us this year, and hopefully we'll rally around this question. All right, Alex Delcid is watching for questions from our community. Alexis, how are you? I think I said Alex. Man, it's a tough name morning today.
That's all right.
It's my first day back, man. It's first day back.
I've been called worse.
Okay, well, Alexis.
We have a question. Well, actually, Jeremy Yenser, one of our loyal viewers, wants to share some thoughts with us on the food allergies. He writes, the anxiety of eating really resonates. We have a lot of dairy allergies and celiac in my family. The biggest surprise for me was that even checking ingredients isn't always safe, like caramel color sometimes means wheat and sometimes not, depending on the company. And some spices like oregano, if they have anti-caking agents, can mean flour. Boy, that would be frustrating. I miss the days where my family could just go anywhere and eat. Now food can feel more like a chore than something enjoyable, and food allergies really inflate the grocery bill. Dr. Love, I bet you hear that from so many of your patients.
Yes, it is heartbreaking to see people with food allergies and difficulties acquiring food, access to food, having food insecurity. And there's so many factors at play there with social determinants of health, and it can be really a difficult situation, especially for working families that have two jobs or don't have transportation, and they have to go to one grocery store, but they don't have the safe foods that they need, so they have to go to another grocery store across town. And so it's very anxiety provoking for a lot of families.
Sally has a question about the graphs that Dr. Hawkinson just showed us during our segment with him. She wants to know if those graphs mean we are doing better than we were this time last year.
What do you think, Hawk? Are we better than last year? Or is it
I think
lack of reporting.
Yeah, it's hard to tell on the reporting overall. I don't remember the data from a year ago. But certainly we know that if you see on the far left side of those graphs, there was a very high amount of hospitalizations in emergency department visits. I think that was from July. So I think we are a little bit. We do also, we have said for the past now couple of years, we do expect those fluctuations, maybe peaks 2 or 3 times during the year, not just during respiratory viral season, which is typically October to April or the end of March. So we have luckily had a low amount of cases overall and hospitalizations and deaths, as well as ED visits. But I think we do expect those fluctuations probably 2 or 3 times a year. And overall, yes, we do hope to have, number one, decreased hospitalizations and, of course, decreased deaths as well. So far we are doing much better. And then if you look back to 2020 and 2021, we are much improved from those data from those times as well.
Yeah, I think it's gotten better, right? But
yeah.
Even if first of all, one of the graphs had an August 9th date. We don't get daily reporting anymore. Yeah. And so it's hard to make those graphs. You get these trend lines, you get dots that are 2 or 3 weeks or 3 weeks apart. So you have a lot of time where you're kind of flying in the dark. What I'll say is there's a lot of my patients have COVID right now, a lot higher testing, or not that people aren't testing more, but we're being told of more positive tests in our patient population. And so my suspicion is it's higher in the community. Hospitalizations haven't risen as much, which is good news. I don't think we expect them to. If you look at the influenza pandemic in around 2019 and 2017 and 1917, 1919. After about 5 years, the numbers really kind of went back to baseline. I think we'll see this with COVID, but you don't ever know if there is and this is where public health helps us. If the virus has a mutation that does make it more severe, it's going to take us longer to respond to that because we don't have the data and the information because we have, we've really taken out a lot of public health. In our country.
And I think that's the key point that Dr. Stites has made, and we've said this, even for the past, year and a half, couple years, we have said there are caveats to that information. Number one, because people aren't testing or people aren't going to the hospital to get tested, or because they're sick enough. So that is a good thing. Now, in this particular public health climate, we are seeing even greater caveats with the data collection and the ability to report it as well. Overall, the data does look better. We know that we do expect certainly less deaths, less hospitalizations than we had seen the previous 3 or 4 years. That is always a good thing, and we should continue to endorse the fact that we know, even for low-risk patients, we know that there is overwhelming data to support the safety and efficacy of getting vaccinated and staying up to date with vaccine, particularly for COVID-19, because this can help reduce symptoms, duration of illness, and of course severity. So we know that the vaccines currently are not available. We know there is a lot of concern or questioning about what is recommended, who can get it. We will be reporting on that and describing that to everybody to help reduce that confusion once the vaccines are available. Currently here at the Haas Health System, we don't have the COVID vaccines, and I don't think really anywhere in the community that the vaccines are available.
Not the new one, at least.
Yeah, not the new one. The other one got taken off the emergency use authorization, so nobody should be using it at this point in time. But once they are available, we will help inform you who can get it, when can you get it, and all of that information, because we know now there's a lot of confusion out there.
Yeah, I think the most recent thing is over 65 and those with severe underlying disease. Like I've had a couple of lung transplant patients ask me yesterday, could they still get it? And we researched, yeah, they can still get it. I mean, they could once the new shots and the shots are available again. I think that'll be the rule. But you know, it's constantly changing, and the battle, which is just not scientific at all, which drives me a little crazy, against messenger RNA vaccine. It's all emotional and political, and keep that out of here, please. Keep it out.
Yeah, as we have said, the overwhelming data support the benefits of the vaccine and the safety of the vaccine. We will certainly help describe FDA and CDC recommendations versus now. We know that the independent medical societies are going to be making their recommendations as well. Some of them already have. For instance, for OB-GYN and maternal and fetal medicine, we know that ACOG, which is the main body of OB-GYN in the United States, has their recommendations. We know that the American Academy of Pediatrics, which is the main body of pediatric medicine, has made their recommendations as well. Once those vaccines are available, we will help delineate and go through that for everybody so they know what they can get and really the best way to go about getting those.
You know, bodies of scientific groups have kind of had a different recommendation than what HHS is having right now. Okay, Alexis, sorry, we could go on this rant for a little while.
No problem. Jill has a question about allergy shots. Jill shares that she took allergy shots for a corn allergy as a child, and Jill writes, I'm no longer allergic, so why can't children with peanut and other food allergies take shots?
That's a great question, Dr. Love.
Yeah. So food shots actually are not as safe as we think them to be. It hasn't been proven to be safe for all populations, and so that is still not FDA approved. However, we have other agents that we can use, like the oral immunotherapy that is the peanut desensitization, and some in research trials in the pipeline for other foods. We have the skin patches, we have the sublingual tablets that are in the pipeline. And I forgot to mention earlier, we already have an FDA-approved product for a biologic for food allergies that helps not cure the food allergy, but make life a lot easier in the sense that it reduces your risk of a severe reaction if you should accidentally eat your food allergen. So that helps with quality of life for patients. And I just had a little boy tell me that he did not want to go to school leading into this fall because he was so nervous about being around other middle schoolers and what they would say to him, and didn't want to go to the lunchroom, and you know, that can be distressing on him and the whole family. And so I said, you know, what do you think about this shot? It's just once a month. It'll help reduce your risk of a severe reaction so that we don't have to worry about going to the emergency room every day that we go to school. And he went for it, and he's so much happier now.
That's awesome. You know, science does work, right? Science does work. This has been a great discussion. Final thoughts from our guests today. Dr. Love, let's start with you.
Gosh, so I think the most important thing is recognizing that food allergy is a chronic condition. Knowing what to look for. We didn't go into that too much, but learning about the symptoms of a food allergy reaction is important. And then, of course, calling your neighborhood friendly allergist.
The neighborhood friendly allergist. Awesome. Dr. Poblete, and by the way, Dr. Poblete, we're so glad you're here in the Midwest and not in California. And thanks for the great work you and your organization do. Final thoughts.
Yeah. I want to share that FAIR offers a wealth of resources, whether your child are newly diagnosed or have been managing food allergies for a long time. Visit foodallergy.org to find expert information that can help guide your journey. Through our 15 and FAIR initiative, we work closely with Dr. Love here in the Kansas City area and welcome everyone in the food allergy community.
All right, well, thank you. Doc Hawk.
Yeah, I think it's good to be back, and we know we are getting into some further troubling times, public health and medical times in particular. We will try to keep you informed so that you don't have to be fearful, but you will have the best information to protect yourself and your family. And again, once the vaccines are available for COVID-19 this year, we will help you understand who and when you can get the vaccines. We know also that influenza vaccines are available around the city right now. Currently, influenza activity is very low. Certainly, we don't want to miss an opportunity to vaccinate if you are going to see your physician. But otherwise, right now, influenza activity is low. Don't recommend it just yet, but we will keep you informed and try to keep you and your family and the whole community safe.
You know, it's been a few months since we've been on this show live. You know what hasn't changed? The impact of faith, hope, and science in our lives. You just heard Dr. Love tell that amazing story, that young child, this one child who was having trouble in school, was afraid of going to the lunchroom, and through science gets a new shot, and he's so much happier. Faith, hope, and science. It really does work. You need to listen to people who actually do it, not to people who just talk about it. So that impact in our lives is so immeasurable every moment of every day. We have to trust each other, we have to have honest conversations, and we have to believe in the science. Thanks everyone for watching, listening, and hearing about faith, hope, and science again. We'll see you next week.
I'm Alexis Del Cid on the Season 8 premiere of All Things Hard. Pregnant with her second baby 2 months after giving birth to her first was a big surprise. But the biggest stunner, being told she was in heart failure. The unique way cardiologists are using a mechanical device to save her heart. Thursday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.